Hi, everybody. Welcome. We will welcome everybody. This is Dr. Reed Van Ham from TOEFX, and I have here Dr. Patricia Nicholas. We will wait for a few more minutes and then we'll jump in. So, welcome everybody. Patricia, 30 something Fahrenheit is all relative, right?
It is. It is. Good evening, everyone. Happy to be here with you. In Florida, I'm thinking it's freezing here. And I'm coming to New York next week.
Yes, exactly. You will miss this.
I know. 60 degrees in Florida is like 30 degrees in, up north.
Yes. Okay, so welcome everybody. Hi from freezing Canada. I'm delighted to open this webinar. I'm very excited to have Dr. Nicholas here with me today. I'm going to introduce her shortly. But before, just to bring all of us that will be on the same page, I just wanted to briefly introduce you to TOEFX. So MeTOFX, we offer a complete business unit end-to-end for the treatment of onychomycosis. We created cutting-edge diagnostics. We slowly launched it in the States. We also created innovative light therapy for the treatment of onychomycosis, which you know that onychomycosis is a huge problem and its effect depends on the age, but between 20 to 70% of the population. So just about me, maybe you're wondering what brought me to this glamorous world of toenail fungus. So I'm a problem solver, and I found this area very challenging to treat. So we have developed this technology. Um, do I have some background noise or it's okay?
It's fine.
Okay.
It sounds good. You sound good.
Okay. So just about me, I have a PhD in toxicology and pharmacology. I worked at Teva Pharmaceutical for many years and in Canada in Ontario Ministry of Health and Long-Term Care. I'm an expert in toxicology and I'm the co-founder and chief technology officer of TOEFX. So this is the technology. You can see here kind of purplish light. The reason is that it's a combination of red and blue. They work together to eradicate fungus. It's a very strong light, which is able to penetrate the nails. However, it's not laser, so the mode of action is not heat. TOEFX is performed by clinician. So there is no worries about patient compliance. It requires about 5 to 10 minutes of your time. And the entire process, we did it very simple so it can be done by assistant. So why did we choose light therapy for severe onychomycosis? First, it's a very good alternative for patients who can't or just don't want to take oral medication. It's non-toxic and safe, and actually, light therapy or photodynamic therapy exists in other modalities in medicine, such as cancer treatment, in dentistry. They also use, like us, a combination of a formula and a light. So basically, we took the knowledge and made it work for onychomycosis. So light therapy has no pharmaceutical ingredients and may, if needed, combine with topical or orals. there is no contraindication. I'm very proud to say that we got accepted. We submitted our clinical data to the Journal of the JPMA. It was accepted for publication. It's going to be published in March 2026. And basically, we looked at 165 toenails, big toenails. Most of them were severe. The reason that we looked at severe cases is because we started the first clinical study together with COVID. The recruitment was tough. We had severe patients, and we really wanted to get going with the study. But we realized that it's working amazing for severe cases. The reason is that because the formula penetrates very well, so does the light. So it's managed to get to the nail bed. So the efficacy is 73%. It's 100% selective. I will explain why. And it requires only 5 minutes of your time. So this is our publication. We looked at 101 patients, 165 severe cases. The average age is 60 years, and 80% of the patient had chronic infection for over 5 years. So those are some before and after. So this is the before, and this is after 6 months. The blue, don't worry about that. It just traces of the formula. It will wash away off over time. So the improvements is really amazing. Just a little bit about the mode of action. It's really cool. So you need 3 components. The first one is a photosensitizer. We developed, actually we have a patent on that. It's a compound that knows how to absorb the light. We made it, you can see here, in such a way that it doesn't look like a drop. This is a regular water drop, but we played with the surface tension. So we made it in such a way that it penetrates really well through the nail plate into the nail bed. So photosensitizer, a light. So the red light that we have works with the photosensitizer and the oxygen, regular available normal oxygen, to create reactive oxygen. All of these mode of action is done in the cell membrane. What's nice that the photosensitizer has a very good affinity to fungus or bacteria, to microorganism. So it's very selective. So it doesn't do anything to normal cells. What's also cool about the formula, it's stain predominantly infections. So you can see this is a confirmed case of onychomycosis, and this is 2 weeks later. So you can see only the infected area is stained blue. You can use it as a marker to show the patients the progress. I think Dr. Nicholas will show you some pictures after. But also it's a really nice area for you to focus your attention, because you know that the rest is healthy, and you know that this area need to be probably more debrided, or it will help you to see the progress. The protocol is very simple. You just prepare the toe, apply the formula, substantial amount, wait for 5 minutes for it to penetrate, and then the patient sit under the light. The light is designed to treat all 5 toenails at once. This is my contact information, my cell phone number. I'm happy to get texts. Normally I reply even if it's late. My email address, and this is our website. So now we are going to talk about real clinical results from a podiatrist that's using our technology for a while. Let me just introduce our expert today, Dr. Patricia Nicholas. So Dr. Nicholas practiced in podiatry medicine over 30 years with extensive clinical experience in onychomycosis management. She currently practices in orthopedic surgeon a center in Florida, bringing collaborative experts in multidisciplinary care. She's a certified professional medical auditor. She's a diplomat, American Board of Multiple Specialists in Podiatry Board, certified in lower extremity geriatric medicine. She principal healthcare consultant with Pulsewife Consulting and past president of New York State Podiatry Medical Association. I met Patricia, I think 1 or 2 years ago. I was very impressed with her capabilities, skills, and I love the way she managed her practice. And I asked her to join us today. And I'm very excited, Dr. Nicholas, to have you today. Dr. Nicholas will also join us at the New York conference and the SAM conference in Florida. So in a week in New York and then SAM conference. So feel free, if you are there, to stop by our booth and talk to Dr. Nicholas. So
Thank
Dr. Nicholas, the floor is yours.
Thank you very much. I'm excited to be here. I love the product and I use it in my practice, and I'm happy to share my experience with TOFX with you. Let's start by saying when I treat my patients, I don't consider him as TOFX patients. They come in because their initial reason they come in is for fungal nail. They tell, we put in the notes, reason for visit, they say fungal nail. And most of us have been treating fungal nail for a long time. We know how difficult it is to treat, and the patient know how difficult it is to treat. So I do the initial visit. You can move the slides, please. Okay, so on the initial exam, I do a thorough examination, and I explain to the patient what are the treatment options they have for treating onychomycosis. And then based on that, I can develop a treatment plan for that specific patient. Not every patient that I see for onychomycosis do TOFX, but I give it to them as an option. Give it, please. I need you to move the slide, please. Thank you. So you have the control. So
next slide.
Yes, please. So when they come in, I explain to them the different treatment options. So I start with the old medication. They all heard about it, terbinafine, diflucan. I explain to them the efficacy rate of terbinafine or all antifungal. And the first thing they all tell you is I have liver disease, I have kidney disease, I have heart condition, or they tell you I've taken it, it doesn't work, I don't want to take any pills, I take too many pills already. So that already telling you what they're thinking and which way they're doing. They're going with that. So, but I still tell them, even if they tell me they've been to several podiatrists before, even they tell me there are different treatment options before, I always do my due diligence because I want them to hear it from me what their options are. We talk about topical solution. They've already bought the over-the-counter cream. They've already gotten the ketoconazole, cyclopyrus, all kind of topical medication, and it's not working. And then we talk about maybe removing the toenail. If the nail is so thick, and I tell them they still cannot penetrate even if you use a topical, ketoconazole, whatever it may be, if the nail is too thick, there is no way that medication is going to penetrate. So we talk about all the different options available. I even talk about the laser. I don't do laser in my practice, but we talk about the laser treatment, and then I tell them about the TOFX therapy. Move the slide, please. Next slide. Okay. So after I do all of that, I talk about education with them. That's my next step, even before we even do all the treatment. I tell them no matter what treatment option we choose for you, you have to do homework. And I have my staff have a whole list. I made a special list of explaining to them about fungus, the efficacy rate, and I tell them they need to do daily food hygiene, they need to soak their feet, they need to spray their shoes, they need to clean their showers. And we are going to that very extensively. No matter what treatment your patient choose or you choose for your patient, if they are not doing their homework at home, it is going to fail, including with effects. Because most of the patients that have onychomycosis long-term have a genetic predisposition to it and is going to be reinfected. I explained to them how if you have a cold, you get treated, you get back, you can have an abscess, you can have an abscess again. So I manage my patient expectation all the time. We also have great success with the treatment, but if your patient thinks they're going, sometimes you give them the ketoconazole cream, they come 2 weeks, or come out 2 months later, it's not working. It's not intended to work in 2 months. So I do an extensive time, explain to my patient their job. They have to wash it, and I tell them, put that sneaker in the washing machine, dry it, spray. I talk about topical spray sometimes. I talk about tenactin. There is some other product that I use because they can get that over the counter. I talk about the UV light sanitizer that they can get, but they must disinfect their shoes every day on a regular basis. They have to clean their showers. And I also give them a prescription for biotin. Even though biotin doesn't do anything for the fungus, but the biotin strengthens their nail, give them beautiful nail as it's going out. And almost all of my patients are taking biotin as part of the treatment regimen. Next slide, please. Okay, so when they come for their initial visit, almost always I do a fungal culture. I said almost always because there are some instances that I don't do it because the patients have been diagnosed already, or the patient wants to start the treatment today. They don't want to wait. They're like, I want to today. I already know this. I've been diagnosed with this. Nothing else is working. I'm ready to start the treatment today. In those cases, we don't take the fungal culture. But most of the time on that initial visit, when I do explain the treatment option to them, I will do a fungal culture. I will have them return in 2 weeks. We will discuss the fungal culture, and then we decide. This is why I give my patient, we're not rushing them, not making them feel like we want them to do this right away. They can go home, have a folder of all the information I've discussed with them. And then when they can come back, I say, this is your result. These are what we spoke about. I can go over it again. And what have we decided to do? I recommend, and sometimes I tell them, I don't recommend TOFX because you don't have severe, moderate to severe. In my experience, if it's not moderate, if it's mild, I will not do TOFX on them. So I will only do TOFX on moderate to severe because I've seen better results with these cases. So I will tell them, I recommend you, we do this instead. And sometimes I do combination therapy. And the patient wants, I want everything because I want everything, Dr. Nicholas. So they'll get the terbinafine, they won't get cream topical because while I'm doing the TOFX treatment, I don't let them do any topical. So we'll talk about what I do at the end of the treatment. Next, please. So most of the time, when the patient come in with onychomycosis, we know it, they have tinea pedis. They think is my skin is dry. They tell you, oh yes, I have dry skin, but we know that fungus from the nail it goes to the skin and vice versa. It's strange. So I always address the tinea. Sometimes it's just, if the patient is just cream, I will use ketoconazole, cotrimazole, all the array of topical available. If the patient is healthy, they just don't want, they just want to take long-term terbinafine. Sometimes I can talk them into just taking it for 10, 15 days. That clears up faster for them. And some of the time they agree to do that. Of course, if they have hyperhidrosis, which is a bad for fungus growth, we'll talk about the socks, all of those things. And I also give them prescription, the array of prescription, compounding medication you can give to the patient. But I always, and do you have sweaty feet? I examine their feet, it's a full exam. So I know exactly what are the other factors that can affect the efficacy of the treatment we are going to implement. Next slide. Okay, so how do I implement the TOFX in the office? The first visit is the most time I spend with the patient. The other visits, sometime I'm in there, and most of the time I pop in and say, hi, how are you doing? My staff does most of the work, okay? I do the initial debridement because I need to get to the level where I think I've gotten most of the nail, and I clean the debris, I get it to look healthy. They're even impressed by just doing that, most of the patients. And then this way we can start the treatment correctly. And then my staff comes in after that and do the whole treatment. They will clean, we'll talk about the next steps. We'll clean the foot with alcohol. They will apply the antifungal serum. They will put the patient under the light. They will talk to the patient and say goodbye. And on that initial visit, that's when they will do all of that. So I basically do treatment number 1, and they will do the rest of because we recommend 10 sessions, so they will do the next 10 sessions. I come back usually, if I don't spend a lot of time with them during the other treatment, at the last treatment, my staff will come and get me because I want to explain to them what I expect from them, when I want to see them again, what treatment I want them to do after that session. And so we have them to come back for follow-up. Usually I schedule them 8 weeks, 6 to 8 weeks after the last session. And then I explain to them that what we're going to do for the treatment. Next. Okay, so I was saying that the staff does most of the work. So that's why I think it's great for the patient, great results, but also it's great for your practice because you do not have to be the one that spend that half an hour doing all these things. So my staff, I've trained them, and it's not difficult. I have a step-by-step paper for them. They read it the first time. The first time we do the first patient, we all do it together. This way we know the flow. After 2 or 3 patients, they got the flow. I just say patient needs to FX in room 1, and then they'll go and start the process and tell me when I have to go back to do the debridement. So they give the consent form to the patient. They take the payment at the time of the first visit. I do not go back in there until all of that thing is done, that the consent is being formed and they've collected the payment. And they have all the instruments ready. They do the initial picture, and then they do all the cleaning, and then I go in. So they do all that, and they tell me, now you're ready to go. So I'll go, next slide, please. I'll go do the debridement, and then they'll document. I made templates. So I treat that patient as a regular patient. The initial visit, you don't know what treatment they're going to be. It's a regular visit with their insurance or whatever they're paying. But once they pay for their 2FX, now is a cash paying service. But I still chart it as if it was a regular chart. So I have templates. We have a template that the document to tell us that we did that procedure that day. Then they will do the step. They will clean the area with the alcohol, let it dry for 5 minutes. They will apply the serum. It's blue. We have a lot of men doing this, and then we joke about it, like, how do I do a blue? I'm like, okay, so it's fun. So you want your toenails to look good afterwards. So they put the serum, we wait for it for 5 minutes more, then they go under the light. The light has an automatic shut off in 12 minutes. So when they're done, they're done. The first time the staff, the first couple of times, my staff will go in and say, oh, you're done. Okay, so we'll have you come back in 2 weeks, we'll see you in 2 weeks. So we pre-schedule all the appointment on the first visit. So they have their appointment every 2 weeks. Sometimes they have to change it around, but they all know how to do that. But they get their paper with all their 10 appointments scheduled. And then the staff will tell them, we don't want you to wet the foot. You can take a shower, but we want you to soak the foot during the treatment. So we don't let them do anything to the feet for the first 4 visits. Next, please. So these are pictures from my practice. You can see this is initial visit treatment 1. It gets debrided. We keep putting the 2FX serum on it. You can see the blue in the corner. This is treatment number 8. You see how the new nail is growing. And they usually, by the 7, 8 visit, they really get very excited, the patients, because we tell them the nail takes 6 months to grow. Even after the treatment, the nail is going to continue growing. and they really start getting very excited. And in my, like I said, in my experience, the more severe the toe effects, the more drastic they can see. Next slide, next case. Yes, you see, this is the initial, first one is the initial one at treatment number 4, at treatment number 9. Next, please. Same thing, different patient. This is treatment number 1, you see treatment number 4, treatment number 9. How are the toenails looking? They're going to go out. So the patients get very excited. We get excited. Once in a while, you said, "Oh, I don't know if it's, if it's working." So I always do the old-fashioned thing. Let's roll the tape. I tell this, and then they all laugh. And then we pull the notes. That's why you have to take the picture and do a regular note. And we'll pull the note and we'll show them the first. And then they look down. They're like, "Ooh, it's looking better." Yes. I have a couple of patients, I have to say, not the whole, one of the two of the nail, because sometimes they have multiple nail, they have one nail, and some of them, one of them like give me problems. So I always tell them, it might not work for all the nail, but we can remove that toenail, and then we can just do topical action on it, and they always, so we have real live patients. Not every patient is the picture perfect, like a book, like I'm showing you. Once in a while, you'll have 10 toenails, if they all cleared up and there is one that is giving you a problem. This is very thick nail, and it's, so I tell them, and they know, yeah, I know we might have to remove that. So again, managing the patient expectation is key for you and for the patient. Next. Okay, so 10 session, we tell them at the initial visit is 10 session, 12 minutes is for the light. In my practice, we try very hard to give them half an hour appointment, because by the time they get from the waiting room to go to the room, we set them up. And, if they need to be debrided, sometimes they need to be multiple, by the time the 7 visit, they might not need any debridement. I have staff that can do it too. But the first few, you might need to debride. So that takes a bit of time, especially if I'm seeing other patients. So they might stay in the room to wait for me to go from another patient to them. And I tell them it takes 12 to 18 months for the nail to fully grow. So we have to monitor that. So again, the patient expectation, but usually after the 10 session, they see so much improvement, they're really very happy. Next slide. Revenue. I'll talk about that because I practice. So I don't know, Irit will talk about that, about the cost of the unit, but I can tell you the average fee that we charge for the 10 visit total is $1,500. But of course, different areas have different price points. So some area you might want to charge $1,000. Some area you can charge up to $2,500, $3,000, because people, depending on the area you're practicing at. With 5 patients, it's about $7,500 you collect. And then if you only do 5 patients a month, if you do 5 new patient every month, because the sad thing is once you get the first 1,500, they're coming for 10 visits and you're not getting the money, but you only need 5 new patients every single month, your annual will be $90,000. And I'm excited about this for a couple of reasons. First, it works. I've seen, I tell my patient is almost as good as taking the terbinafine or any oral for that matter. And then you get ancillary revenue for your practice. And, we all know about audit. I do audit, I'm an auditor. E&M, we're about E&M audit, 11721 audit. Once that patient pays for the services, they sign the consent form, there is no auditing, I want my money back. You don't have to give that money back, and you're doing a service for your patient, a treatment option for your patient that cannot take the oral, that has been unsuccessful with all the treatment. You increasing and giving positive treatment outcome for your patient while it is a revenue stream for your practice. And you can, and then I think it's wonderful. These are other numbers, for 10 patients, you get 15,000. So incrementally, the more patients you have in your practice, the better. Most of the patient comes from our practice itself because I'm in a group, and I have a lot of onychomycosis. I do a lot of nail care. And then we do advertisement in the health magazine in the area, and I get a lot of that. They'll come with the magazine in hand, and they'll show me, oh, I read your article about the blue toenail. I need to do something. And we've run it about once or twice, and we still have patients months later bringing the magazine with them to the office. And some of my other colleagues had a patient yesterday, and one of my other colleagues said, you need to go see her because she's on the two effects. So there's a way you can do internal marketing based on where you are, or you do external marketing. It is a very well received. The only downside is that some patients, they want it, might be cost prohibitive. So you have to see how your practice operates, what is your area, your price point. But I think if regardless of if it was in a cash paying service or not, I think it's a great product and it works very well. Patients are very happy with the result because they've been battling this fungus for a long time. Next slide.
Dr. Nicholas, can you, I think you told me that you have now around 30 patients overall with toe effects?
We have more. I think my staff is on the line, but it's, I mean, Dr. We have more than 30 patients. We've been doing this for a while. So we might be close to 40, maybe 50. So we have a lot of patients that, every time I'm in the office, and sometimes I'm not in the office, we have other doctors in, the patient can still come to do the treatment. So now my staff is so well trained, I do not have to be physically there myself. They're on my schedule, and we have other doctors in the practice. So my toe effects patient come for their treatment.
I just wanted to make sure that I understand this graph, because I think some of the digits are hidden. So this is 5 patients, 10 patients, 15 and 20, I guess, right?
Yes.
And the left column is monthly and then annually, right?
Correct. I think the transfer from the Mac for when they transferred it to the PC kind of shifted because I have a Mac. When I sent you guys, I think it just got shifted. So yes, so the lower one is how many patients, which is 5 patients, and the blue is the annual revenue from if you get 5 patients every single month. And if you have a busy practice, it is very doable. And if you have 10 patients a month, which is about 2-3 patients a week, so you can do 15,000 a month, and then for the year is 180,000, and so on. You just multiply by the 15, whatever I'm basing it on an average of 1,500. So if you're doing 2,000 or 2,500, of course the revenue goes up. Thank you so much. I'm open to any question you may have about the treatment, what I tell my patient, how I do it, and I have my number. You can text me, call me, and I'm happy to discuss or whatever questions you may have right now. I'm open to answer.
Okay, we do have some questions.
Okay.
The first question is, what dosage of biotin do you prescribe? And do you still prescribe it for patients with thyroid issues when it can affect thyroid labs?
Okay, so most of my 10 milligram of biotin, that's what I do once a day or twice a day based on the patient. And I don't give it to the patient with thyroid issue. And almost 99% of the patient will tell me, I got thyroid, I cannot take it, because we do a thorough, like a regular exam with them, a general exam, and no, we don't give it to them.
Okay, can you remove the blue stain from the toenail after treatment?
We don't want them to remove the blue stain after each treatment because that's our marker. Like we said at the beginning, that's our marker to see where is the most concentration of the fungus, and we tell the patient that, so when they come again for the debridement, we can spend more time debriding here. And as the treatment is working, it's less staining, so you see less blue. So they don't mind if you explain that to them. I should laugh because he was here today. I have a gentleman, he hates the blue, but he wants his toenail. He complains every visit. I don't want the blue toenail, but he still come and get the treatment done. We all laugh when he comes in, but after a while, as the nail is getting better, the blue stain will go away. And when we debride the nail as well, that most of the blue will goes away.
Okay, so the treatment. Oh, go
I
ahead.
also wanted to add, sorry, something about the blue. So the formula is unique in a way that it has three components, main components. The first one is the blue. It's the photosensitizer that works with the light, but also it has solvents that kills the fungus, and botanical extract that has antifungal and antimicrobial property. So actually we recommend the patients not to wash their feet right after the treatment, to leave the formula on for a couple of hours before taking a shower. And as Dr. Nicholas explained really nicely, you really want the blue there because you can use it as a marker for yourself to know where to debride more. Here, for example, on the side, you see that this side is also still blue. Most probably there is accumulation of fungus. And also it's very cool for the patient because, right, Dr. Nicholas, they see new nail coming in, so they know it's really nice for them to see the blue coming out.
Okay, so the treatment protocol is 10 treatments, 2 weeks apart. That's
Correct.
the question.
Correct.
Okay, can you go back to the treatment protocol slide, the steps 1 through 5?
This, I guess?
No. Go to my slides and see. Go forward, go back. More. This one or the next one? This one? No, go, yeah, the next one. Go. This one right here? So if that's, I hope that's the one, because when the patient come in, the first treatment, we do a consent form with the patients. So the staff will go, I'll explain to them everything beforehand, and then when they say yes, they want the 2FX, my staff will go in and actually give them the consent form, and they will start the consent form. And they'll document that the consent form has been signed. They also at that time collect the payment. I didn't put that on the slide, but that's when they'll collect the payment after the patient does the consent form. They collect the payment. Then after they collect the payment, they kind of wipe the patient's toenails, and then they'll do a baseline picture on their cell phone, because we have our EHR will upload it automatically. They will do that. We crop the pictures for the presentation, but they do the entire 4 foot. And then that will upload into the system. And then after they do all of that, then I go in to do the debridement. I hope that answers the question.
Okay, next question. Not sure I understand the mechanism of action.
That's for Dr. Vinham.
Okay, let me go back to that. So the mode of action is basically taking ambient oxygen, regular oxygen, and turning into reactive oxygen. The way it's done is basically the energy of the light. So, okay, first thing first. The photosensitizer, which is the blue formula, penetrates into the fungus membrane and just stay there. It sits there. Once you shine the light, the energy of the light goes through the photosensitizer. It's kind of a mediator or enhancer. It enhances the energy of the light, and it's transfer the access of the energy to an oxygen, which become reactive oxygen, ROS. So this is the area inside. Reactive oxygen tend to be very reactive, and they basically destroy the membrane of the fungus. So the fungus, it's killing the fungus, and then the oxygen goes back to the baseline, and it repeats itself again and again until the light is turned off. So it's pretty cool because the blue formula has very high affinity to cells that divide rapidly. So fungus, bacteria, yeast, or mold. So it penetrates much better to those microbes rather than the skin. So everything that I showed you here, the reactive oxygen, is done only in the infection site. So although it's light therapy, the mode of action is not thermal. So it's basically oxidizing the membrane of the cell. I hope I answered the question.
Can patients use nail polish on the top?
Absolutely not. Nail polish should be, funny enough, I did not allowed to use nail polish until after the treatment. It's blue. I tell them it's blue nail polish they're going to be having for the next 10 session, for the next 20 weeks. And they're okay with that. And even if I don't do toe effects, all my fungal nail treatment patients, I don't like them using nail polish. First of all, I have to examine the toe. I mean, it's an exam, it's a medical exam. You need to be able to see the toenail. So no nail polish. And if they if they want to use nail polish, I recommend, industry, I'm not endorsing anybody when I say names, Dr. Remedy, there's other ones on the market that they can buy, that they can use at home after the treatment is completed. I want to go back to what Irit said. I don't let them wash I don't let them swim. And that's one of the things we tell them, no swimming for the first 4 sessions. Some of them, they really want to do, they're like, okay. Then after that, I tell them they can swim, because when you're swimming, you spend a lot of time in the water, it washes off the blue, the blue that I want to see. So once, after the 4th treatment, everything is settled, I know exactly what's going on, then I tell them they can swim. And most of them, they're pretty good. Almost all my patients, they're very, very responsive patients and very compliant.
They don't want to mess with you.
You can tell.
Okay, do you debride the nails every visit or every 2 visits? And if so, do you bill an office visit for that? Or is that part of the $150 cost per visit?
I debride the toenail as often as I need to. Sometimes, my staff will put them in the room, they look at it, it's not, it doesn't need to be debrided, it's good, they just proceed with the treatment protocol. And sometimes they'll come and get me, because the nail looks a bit thick, you need to come and debride it. So I will do it as often as I need to. So, toward the end, you don't have to, probably the like 8th, 9th, and 10th visit. Once in a while you do, depending on the patient and how bad the toenails were. I do not charge. That is the total cost of the treatment, and the treatment include debridement if needed. The only time I would charge for a visit is if I'm doing something else to the toenail. For example, if the patient come in and they said, I have pain in the lateral aspect of the toe and it's very ingrown and I have to do something to it, I have to prescribe a prescription, I have to do a stand back that day, or we decide we're going to do something else that day for that patient, then we visit. But anything to do with the treatment of the fungal nail, that is part of the treatment.
For severe onychomycosis, do you tell patients that they may need more than 10 treatments?
Very good questions. Yes. There are many, I tell them that we'll do the 10, that is what the cost, is for 10. And I tell them if it's not better, we might need to do maintenance or more treatment. And then they will have to do it or not. Yes, you can definitely tell them that. And the recommended thing is in 8 visit, they should have a maintenance treatment, but most of them after they pay $1,500, and I tell you, I give them a whole homework to do, spray, soap, all kind of things. So they have other costs, buying biotin, So some of them will be like, I want to get everything. I don't want to mess around with this. And then some is like, oh, okay. And you can see the hesitancy in them buying more stuff. So you have to kind of, patients are individuals. Just because we have a protocol, it's not for everyone. So you have to gauge your patient and see if they can afford the extra, or at that point, they cannot afford the extra treatment. When I discharge them on their 10th, I always give them a topical antifungal. And even if they don't have to use every day, I said you have to use it 2 to 3 times a week because you are predisposed to having this, okay? I tell them they have to continue doing the spraying because the nail is still growing and you can get reinfected. Just because we just did it doesn't mean that the environment doesn't have fungus. If you don't keep it clean, you can get reinfected.
Have you seen any patients have adverse reactions?
Not with the TOFX. Actually, today I had a patient that had allergic reaction to a topic compounding that terbinafine, ketokine, all kind of stuff, but I've not seen any TOFX, the antifungus on the serum yet. I've not seen it.
Okay, do you use any other topical antifungals concomitantly?
Yes, not during the treatment itself. While I'm doing the TOFX for the 10 session, we don't use any topical antifungal. So we wait till after the 10 session, then I give them topicals.
Okay, I'm looking here. Okay, I believe that is all the questions.
Can I say one thing about the topical? When I say I don't give them topical, that's for the nails. So if they have tinea, you can give them the cream for the tinea for the skin. But for the nail, I don't let them put anything on the nails.
I wanted to ask you, in which cases you decide to use oral terbinafine together with TOFX or other modalities?
Because I have some, I have older patients, 90, 80, and they're all doing treatment, and I have younger. I have like a 36-year-old. He's young, he's healthy, so he took the oral. We did we did everything for him. So if they're healthy and they're young, they want to do everything because they had it for so long and they think it's very cumbersome to them. It's very ugly. Their friends, they can go to the beach. They want everything, and they're healthy. I'll give them the oral as well.
We have another question, actually 3 questions that just came in. In your practice, what is the failure rate?
Right now, I have one patient that I'm not 100% happy personally with the result, but the patient is happy. I'm looking at the toilet, I'm thinking, I don't know, doesn't look so good to me, but the patient is happy as pie. Oh, it looks so much better. But to me, it's almost like a failure rate because the nail is not as clear, not as thin that I would like it to be.
So it's 1 out of how many cases? 40?
40? Yes, yes.
Okay, second part of the question. Does removing a nail prior to treatment have any effect on the treatment?
My personal opinion is that I think it'll be better. And secondly, if I'm going to do that, and I tell them, I have a couple of patients I've told that the nail is so thick, I'm like, we're better off taking care of that toenail. I will wait till the 2 weeks post nail avulsion after it heals to apply that serum and do the treatment.
Okay, and the third question, what is the cost of the equipment?
That would be for that. I don't know. So
we have a really good promotion for this webinar and the conference to come, and we are going to send it your way. So just a heads up, please expect our emails in the next few days to a week. So we'll send few emails.
Okay, the questions just keep coming in. Is it safe for diabetics?
Definitely, yes.
Okay, and is there any difference between TOFX LT2000 double light and the regular TOFX 2000, and from where do you require the device? I think that should be from where do you acquire the device?
So the model that is available in the States is the 2000 light. The 2000 light is a combination of two wavelengths, blue, which is 420, and a red, which is 660, both in high intensity. As I explained previously, the mode of action is that the red works with the formula, and the blue light works on the superficial infection, so on the nail plate. To those who have a specific question about the different models or the price point, you can text me or email me. So my telephone number is 289-816-4047. You're welcome to text me, and my email address is irit@toefx.com, or you can go to the website and send the request, so I will be happy to respond.
Okay, what is your topical preference following TOEFX therapy, and for how long? And then second part to the question, how long do you continue biotin after therapy?
Okay, my preferred topical is EBM compound and 45. They'll be at the conferences too, I think. I think they are. So they have several compounding things, formula. So I like the N45. And the biotin, I usually tell them to continue it. They like it. It's good for their skin and their nail. You know, it's not going to harm them. If they choose to stop it after the nail looks beautiful, they can. But I tell them to use it for another 6 months or so or more after that.
It's a supplement, right?
Yes.
Through the mouth. What's the dose that you recommend? There are different.
10 milligram, and I use the formula from EBM as well. They have a formula there. It's a compounding company, EBM, out of Tennessee, that we use in my practice.
So they have biotin with something else, right?
They have zinc and collagen in there.
Zinc, and yes, collagen, exactly.
Yeah.
Patricia, can you describe briefly the protocol that you ask the patient to soak their feet, and maybe in more details a little bit?
Yes, so when they do the TOEFX, I don't let them do that, but before we decide to do TOEFX, and if they're not going to do the TOEFX, my patient have to soak their feet. We have a type of protocol for them. So they need to soak their feet. So I've changed it over the years. Years ago, 25 years ago, they just used to soak in Epsom salt and apple cider vinegar, which has some antifungal property. They can get it anywhere for 10 minutes. No more than that. I don't want them soaking in the fungus. And so I'm like 10 minutes to cleanse the foot. And then I make them use, now that they have more choices on the market. Some patients, I tell them to soak with Epsom salt based on the patient, revenue, everything. And some patients, I give them an antifungal soap to do. We use a specific company. I don't want to endorse all these companies. I use I have a protocol, and there's a lot of companies I use for specific things. We use Dr. Antifungus soap and spray for them to soak. Right now, they'll get it out and sales. We have a pharmacy in our practice. And then they will then put a topical, I will order the topical for them. If it's N45, it's ketoconazole. Basically, they have, and they can afford the N45. They can only afford the prescription from their insurance plan. I'll give them the ketoconazole. I make them do Vicks Vapor Rub, okay? Because I need them to penetrate. So I will have them use Vicks Vapor Rub on the toenail because they don't have any urea. They cannot afford the urea. They will put that at night. It softens the nail, and then they'll put the topical. So that's my kind of protocol that I use, and then they have to use the spray on their shoes. Everybody have to do it. And I'll say, did you use the spray? No. I'm like, okay. No wonder it's not looking. So they have to take responsibility as part of the treatment. Yes. So I do a lot of different things, different of the patients. After they finish the treatment, if they want to soak, go soak. But during the treatment, because I don't want them swimming for 4 sessions, I'm not having them soak for the first 4 sessions for sure.
Next question. Is this a mycological cure based upon testing?
Yes, the mycological cure is 59% based on our clinical study.
Dr. Nicholas, an attendee wants to know your email address. Can you say it one more time, please?
Maybe
Okay.
I can share. Maybe I can share this.
The phone number is there, but not the email. I can give them my personal email because I have 2 different emails. So the phone number you can call me is my business, it'll be 917-558-0608. And the phone is there. The email you can email me at will be drnicholas.patricia@gmail.com.
Okay, somebody wants to know if you could provide via email the informed consent you are using.
Yes, once you get the unit from Irit, she will share. There's some things I've given it to her. She will share it with you as part of the package, I think.
Yes.
And I even have the template for the procedure template is in there too. And then you just reuse that template and you put treatment number 1 for the visit, treatment number 2, but it's the same template. Yeah.
Okay, I believe that's all the questions, I think.
I have one last question. Patricia, you explained to me so nicely, and I attended your talk. Can you just briefly explain why documentation is so close to your heart?
Which one?
What? Documentation.
Documentation, because I am a medical auditor. I do medical audit. And even in my practice, I look at my other colleague, I'm like, I don't know. So I'm always looking at the CMS guideline, the LCD guidelines, every guideline there is, because I need accurate documentation to make a difference in your patient life and in your life. We all know, if we are podiatrists, we know about OIG, we know about them, the insurance company wants to take money back from us. We want to be ready when they come, they have nothing to say. So I'm a certified auditor, so I cannot tell people, I cannot audit other people's chart and tell them you didn't have this, you don't have the location, and my notes are not correct. So documentation is key. I have a great staff that learned the documentation. So that's why I think is important for patient safety, patient care, continuity of care. If somebody sees my note, they know what I've done for that patient the day before. So it's very important to me, because we all get audited. If it's not by CMS, it's going to be by your office. I'm in a big group. So I get audited by my practice. And then you can have insurance company audit you for your work, OIG, CMS, insurance. So you need to be ready at all time. None of us are perfect, but we can do the best that we can to make those notes as accurate as possible. And patients have access to portal now. They all have access to look at their notes. So you want that if they go to their notes, they're not going to call you and say, I don't know what you did there. You didn't do that for me. So that's very important to me, that patient have good access, they can read their note and understand it, that anybody in my practice can see it, and then anybody outside of my practice can look at my note and know that exactly what I did for that patient. Thank you.
Okay, thank you, Dr. Nicholas, Dr. Van Ham. Thank you so much. Great information. Good night, everyone.
Thank you so much for hosting us.
Thank you very much. And thank you for attending. We appreciate you for taking an hour and to attend, And if you guys need any question, we'll be more than happy to continue answer them. And we hope to see you in New York and in Florida.
Yes, see you in New York and Florida. Bye.
Bye. Good night.
Good night.